Andrew will give you a couple now of quite specific examples of where we've looked at that.
Thanks. Well, examples might include, let's say, a screening programme where you pretty well know that 50 or 60% of people are going to turn up anyway, so we focus on the 50 or 60% of people who are less likely. Environmental factors, so we have acknowledged, as we set out in the policy review, that these go very wide. We talk about social capital, we talk about health and place. What about examples around these? Well, in health and place, for instance, it's about barriers to accessing support, and then we have physical barriers, which include pointing out transport problems or other problems that people, and expensive transport, whether it be rural or urban, in accessing services. What about the functions of services? Are they there at the right place and the right time? These are aspects of environmental factors. One of the lessons of Go Well, which is a regeneration and health research program that we part fund, it's one matter to move people to new and pleasanter environments, but it's quite another matter to involve people in decisions about that move and cope with the anxiety and reality of rent and energy price rises which they might face, or the loss of family and community ties. And that's all coming out in research that we've contributed to. One of the specific pieces, for instance, coming out earlier this year is the effect of mental well-being on food and fuel price rises, partly because rent rises had not happened at that time and welfare changes had not cut in. But we need to understand that through some of the work we do. Other lessons, healthier, wealthier children, and the benefits of ensuring entitlement to general well-being. And we know that, and we can act on that. In terms of individual experiences, I think there are lots of, again, evidence in the policy review about what matters to tackle health inequalities, person-centred approaches, approaches that are in proportion to the needs of the individual, tackling complex and cross-sectoral needs of people, particular areas for emphasis, co-producing solutions with individuals and communities, and the vital importance of social well-being to healthy ageing, which is a theme to which we've contributed in outcomes work. I hope that gives you a spread of some of the areas where you might give examples.
Yes, that's very helpful, Andrew, and I'm well aware of the commentaries and the research that Health Scotland are involved in terms of the wider environmental influences. But I'd like to come back to the more sort of individual actions, or actions with individuals at population level that you might be taking. And Jerry, you suggested quite rightly that every one of your actions, be it smoking, alcohol, whatever, is assessed for impact on health inequalities. And we know that a lot of these actions have a tendency to widen that gap. The question is, does that mean that you feel Health Scotland should be doing nothing in these areas, recognising that they have an improvement impact on population health, while at the same time often having the negative effect of widening health inequalities?
So I think the healthy range of programmes that we continue to manage and will continue to manage probably is the main answer to that, Aileen. Not at all that we shouldn't have those
just wanted
individual.
That
so let me say it again for the avoidance of doubt, and probably some of my team want to hear me say this yet again, for the avoidance of doubt. I do not envisage at any point that we would not be running programmes. But let me give you an example of where I think this might slightly differ. First of all, our audience might be a different audience. So traditionally, we have focused very much on trying to gear health professionals' intervention with individuals. And yet we know that the main drivers that influence people's health largely sit outside of the healthcare sector. So, for example, our learning and development team have been doing a lot more work about how they influence other parts of public services. And therefore, some of those individual interventions that can be effective can be delivered by other people outside of the NHS. Now, we've known that for many years, but we've tried to, I think, refocus some of our effort around that. But it is a challenge. I don't think there's any doubt that there's a challenge, and we ought to use the evidence in order to shape our programme development, I think at times in quite a different way. Now let me give a very brief example to finish this off. I had the pleasure and the privilege of being last week at Scotland's Dementia Awards, and we were talking about the ways in which carers can be supported in order to help support their family members and their friends and their neighbours live at home much longer. In the past, we would have largely communicated our activity through publications. And we would certainly evaluate those publications and we would try and get feedback on them. But what we also know when we then work with very particular groups, either geographic communities or particular carer groups, is that for us to turn up and leave a bulky published document sitting on the table is not the most effective way to influence the support needs. So, a fairly obvious development we've had over the last couple of years is to deliver much of that information in a different medium. And the example that was being demonstrated to me around that last week was actually just the use of DVD material, where we then interviewed individuals and families who had gone through the experience of living with dementia in order that experience could be shared with a much wider group. So back to the start. I do believe that we probably need to think about not relying simply on traditional Health Scotland products and services. We need to use our intellectual assets, our learning, our knowledge of evidence in order to be able to influence people and influence particularly key decision makers in order that broader impact for a larger group of people who are going to be affected by the kind of disadvantage that we're talking about for that situation to be improved.
Okay, and you talked about working with other organisations, and Ron's going to ask you about working with CPPs in particular.
Yes, and I guess as a precursor to that, an observation, which is that I've witnessed over the last 5, 6, 7 years a shift in the organisational purpose from one which is ostensibly about supporting NHS boards to one which is more focused on supporting partnership, and I think that's been a terrific transition to make. So it's within that context that I asked this question about the support that Health Scotland offers community planning partnerships, and specifically whether you think that you have got it right in terms of the contact that you have with community planning partnerships. How often do you engage with CPPs? Have you met all of them? What resources are you able to offer CCPPs? And importantly, and connecting, Jerry, with that comment you just offered around about influence, have you been able to shape the agenda at the community planning partnership table?
So I'll start off with this, and I think I'll bring George in, again, who might reflect some work that both he and his teams have been involved in. So what I would start off by saying is, although we have been on this journey for the last couple of years, Ron, I don't think by any means we believe that we are, if you like, to use a term that I don't like very much, the go-to partner currently for CPPs. We haven't placed ourselves in that space sufficiently consistently and for long enough to be that partner. But if we are to follow what the evidence tells us about the power of community planning partnerships in organising their resources, particularly within a preventative strategy locally, then we've seen it being our business to take some leadership space there and to offer ourselves and offer what we have there. And so we did a very simple thing this year, apart from our more general work with local authorities and other CPPs. We actually sent our delivery plan to all local authorities, CPP managers and health boards. That in itself prompted a number of requests from CPPs coming and saying to us, we think you've got something to offer us, can you come? And let me just finish my example with a very practical one, where myself and a colleague went to one of the Ayrshire community planning partnerships and met with the local authority chief exec and the community planning manager just within the last few weeks. What she said to me then was, when we were leaving, we are in the final throes of completing our next community plan, and yet we don't really feel 100% confident that we have got this to the place that it needs. We need to work alongside our own territorial health board colleagues to provide the support that CPP needs to just test that. What the particular local authority chief exec said, and recognising, as we were suggesting, that we need this to be a collaborative effort with our local NHS board, because it's the local board that delivers the NHS contribution to the partnership. What she asked us to do was to come and be a critical friend, to look with them as they develop their final draft of that community plan, to say, on the basis of your knowledge and understanding of what the evidence tells you, are we concentrating on the right things? So I think that probably gives a bit of an example as to where we started to place ourselves to say, if we are to influence some of those wider drivers for health, and if we're to offer ourselves into that space, there seems to have been an appetite to invite us into that space. So we've now probably got about half a dozen good examples from the last 3 or 4 months, which came directly, simply by us circulating our delivery document to those CPPs. So George might give a couple of other brief examples.
I think just one brief example, George.
Okay, well, right. Well, let's go beyond the one that Jerry's given them in terms of going to places and acting as a bit of a critical friend. So, we take a number of things with us. So one of the brief examples might be conversations certainly Andrew and I have had with NHS chief executives about connecting some of that other broader work of, say, the improvement service. So, what's the role of the NHS as a key player in a partnership around employment procurement? And, happy to talk through that more over lunch or later, Ian, if you find that helpful.
Yeah, we'll come back to that. I just want to... But you talked about supporting the health board, and Ian's got a question about a particular publication you've used in connection with that.
I think this comes back to, getting Health Scotland to just look at the impact it has on health boards. Does it deliver outcomes? I think, Jerry, you touched on evaluation of some of its work. So I thought there was 2 very good publications produced. One, Reducing Health Inequalities for the Non-Executive Directors, but also Health Inequalities Impact Assessment. I know they've certainly been talked about and used by some of our non-executive directors in our own board, but how do you judge whether boards are using those type of documents, and what's been their impact? How do you assess A, using, and then B, does it make an impact within the health board?
I'm going to pass that on to Kath, but before I do, we know that it is being used now. Certainly, for example, we were at the Scottish Ambulance Service, asked us to come along and talk to their board, with their board, about health inequalities, which they'd started to think about themselves, and we were able to help with some of the background. And there are other health boards as well who have asked us to come along and help support that. So we know that it is being used. I think the question is a question that my board is asking as well: how do you actually measure that sensibly? And is it just about numbers, or is it about, well, what difference does it make? The one thing I would say, in the preface to that document, the Cabinet Secretary himself said that he would be asking health boards the extent to which they'd used that document in their annual review. And I'm hoping that that's been happening.
Write that down for hours.
Well, I hope that's happening as well, because he asked to put a preface to that document, because really underlining how this is seen within Scottish Government and with ministers as well. Kath, I don't know if you wanted to add to that.
Just a little bit. I mean, the resource was published in March, April, so I suppose it's early days, but we did the resource specifically in conjunction with the Scottish Government Public Appointments team, and they've welcomed it and have given us good feedback. We did issue this to all the boards, and we have had a number of responses. Margaret's mentioned Scottish Ambulance Service, Greater Glasgow and Clyde have publicly recommended it. We've just had an inquiry from Tayside. We have specifically followed up invites to Forth Valley and Western Isles, partly on the back of this. So it is definitely, in terms of the first stage of measuring impact, is absolutely having some of the impact we wanted to have. And I think the thing to say about that resource particularly, that's the non-exec resource and inequality, but the health inequalities impact resource as well to some extent. I mean, Health Scotland has produced resources for as long as Health Scotland's existed, so in a sense the production of resources is our bread and butter. I think what is very different about these resources is the level at which they're pitched. They are pitched at the decision makers. Jerry mentioned that earlier. That's our key role here, is to influence the key decision makers about what they might do differently. It's about supporting boards and the local partners to strengthen local partnership's role around prevention, to systematically think about issues such as access into health services. So these resources are very different in that regard, that they are inviting people to have a conversation about what they might do differently at a local strategic planning level. So the resources are important, but I think the key thing is it's not the resource in itself, it's the invites that generates. And I think we've given some examples of what this resource has done, is invite us in to have a different type of conversation with different types of people within health boards, to then talk about, as we've given some examples, what can we do to sit alongside you to help think about how you translate this. So I think that's the key, that these are about strategic decision making, and I think there's a lot of potential for them.
Can I just make an observation as a health board member? I've not seen this document, and that's not unusual, but it certainly is a document that all health board members should see. So there's a bit of a worry for me there that doesn't get the audience that it needs. And just a second observation, I certainly think it should be in the discussion arena around the new developing health and social care partnerships. So if I had an observation to make, it would be to try and extend the reach to the new health and social care directorate at local level. Certainly every health and social care partnership should require at least an initial workshop around how they're going to set about eradicating health inequalities in their areas. So it's a great document. It needs to get a wider coverage in my view.
Can I just say one last
Sure.
thing about that? And it was that this was not just a Health Scotland production. Actually, we very purposefully had a very significant group of non-executives from across boards in Scotland who produced this, and I think that's helped shape that document in a way that, had we done that alone, we would perhaps not have got the level of focus and sensitivity around its particular practical use.
I think that the point for me, Jerry, is the point you made earlier. It needs to be more than a publication. It needs to be a call to action, and it needs to be a call to action on programmes, deliverable programmes and partnerships locally. And that very often at health board level, that engagement is a bit that doesn't happen.
Yeah.
I'm going to take. I'm conscious of time, folks, but I'm going to take you into a couple of questions on welfare reform, third sector, before we conclude with a couple of questions on other activity. And I just want to. I'm going to ask you a general question, and hopefully Kath can come in. How seriously really are you taking the third sector in your work? And you can answer me honestly. But beyond that, to what extent do you think you've demonstrated leadership in mitigating the impact of welfare reforms on health outcomes in Scotland?
I'll just answer the short answer to how seriously do we take the third sector. The short answer is very. So I'll pass on to Kanta.
Yeah, I mean, just to elaborate that a little bit, I remember quite clearly a year ago, the last annual review, being asked, what are you doing about the third sector? And there I think the response was pretty much, we have worked with the third sector for a long time, largely around individual programmes. We recognise that we want to have a much stronger and more strategic relationship with the third sector because so much of our agenda is common and shared. A year on, we have a third sector programme set up. We have a new manager within the organisation, specifically there not to do engagement with the third sector, nothing tokenistic like that, but really help us with that strategic collaboration. And there's already some really strong examples of what we've done with health and homelessness, etc. And I think it does relate to the question earlier about reach for me, that reach absolutely is extremely important around geography, remote and rural, and all sorts of other issues about geography, but equally it is important about seldom held voices. And I think that one of the things we've brought in this new thinking around the third sector to work with is that we recognise we really need to understand the lived experience of people experiencing inequality on a day-to-day basis, and how do we bring that into the work that we do alongside the evidence that we have. And I think that's one of the very explicit things. But I mean, and just to end on one example, a lot of the work that I've been personally involved in the last year is working very closely with the Health and Social Care Alliance on the Scottish National Action Plan for Human Rights. I think that's been a really good example of good partnership working. what we have done as two organisations is really put the sum of our parts together to be much stronger in terms of the different networks that we have, the different ways that we can influence, but we absolutely have a common agenda around that. That's just one example, but I think we can grow in that and do a lot more, so we're very serious.
And I'm very conscious you've done work with the Poverty Alliance as well.
Okay. I'll ask Andrew to answer the question on welfare reform. Andrew.
Yeah. Well, I think from the health sector and broader, with the help of the government, we've really been shaping this task from the start. We started with a briefing paper, workshops involving primary care and the third sector. These workshops taking place this year, in fact one this week, are to clarify roles, responsibilities and expectations, to agree the challenge, but also this call to action that you mentioned. The elements of the welfare, our response to the impact of welfare reform are contained in the plan that we've shaped and has contributed to the Scottish Government-run Health Impact Delivery Group. That guidance involved on the way through SCVO and Inclusion Scotland in devising it. We've also engaged with lots of groups with specific needs, including carers and fuel poverty groups. And we appointed a secondee from NHS Lothian, Kate Burton, to lead the work. So there's been a big investment up front in shaping and following through. Where are we going with this? I mean, welfare reform, the introduction of welfare reform is over considerable time. As a point I made earlier, they actually didn't start to impact on people until earlier this year. But the introduction of welfare reforms will continue on to 2018 at least. So we will follow that through in terms of setting up the agenda, but also following through and monitoring its effects. We've produced papers about how to monitor effects, how CPPs can go about this business without being too prescriptive. We've also done accompanying reports about its effect on children, on work and the chance to work in Scotland, that's what the report's called, and bursting some myths about that, and poverty in work as well as poverty out of work. So we've done a great deal of work across quite a large framework of activity on welfare reform.
Okay, Andrew, thanks very much. And as I've said, that's going to be a hotter topic as we move towards potentially more powers. We're going to move to the concluding session here, which is going to ask you a few questions about NHS facing activity, and Aileen's going to kick us off with her question.
Yes, thanks, Ian. When I asked this question about the health promoting health service, I'm mindful of what Jerry said a few minutes ago about the limited impact that the health service and indeed healthcare workers can have on the determinants of health inequalities. Nonetheless, we have a very good programme which is gathering momentum, particularly since the establishment of the ministerial group last year. So the question is, where would Health Scotland prioritise the actions over the next year or so to make sure that we achieve what's in the current CEL and move on to next steps, whatever that might look like?
Andrew.
Thank you. I mean, the key point is here, we have tried to work in close collaboration with you and the government. And initially we had, I think, a difficult relationship with local boards because they thought we were policemen rather than monitors. But that we've worked through that and it's better now. I think our contribution is now more well recognised, and we're offering more support and shape to the programme. You'll be aware of two key issues that the Minister has, and we are fully behind trying to address them. That's about smoke-free in hospital grounds and around retail, and I can go into that in more detail if you like. But where are we going in future? Well, I don't think we should throw out the framework that we've got. It's very adequate. It covers a lot of bases. What we need to do is develop them and make them more assured. For instance, if we are going to advise people to make lifestyle changes, to make that pathway to support inevitable rather than optional, because we know that optional advice usually is taken up best by people who are going to take it anyway or have fewer barriers in the way. We need to look at clinical leadership and whole organisational leadership for change, because it can't be just up to one or two brave individuals. And these people and groups of individuals need to be in very clear areas of influence. We need to focus on groups, in particular groups, like, for instance, pregnant women and women of reproductive age with respect to smoking choices and alcohol and other issues like that. We need to map onto working with individuals and communities and working in partnership. Partnership is very important here, especially with retail, and that plays in very much to the Marmot framework of making a difference and working for health equity. He pointed out what the NHS can do in that respect. So we need to grow the policy, emphasise areas where we know and the evidence tells us we can make most difference. And what's our role? Well, I think it's to help that agenda setting, strategic leadership we've talked about, providing the evidence about what works, to offer advocacy and help others in that position of advocacy, offer guidance as we do in specific areas, smoke-free being one, provide monitoring data. We've done quite a lot of training and we'll do more. Impact assessment, which has been mentioned before, sharing good practice, and I know we run groups along with the newly appointed champions on that, which I think shows great promise, and creating evidence about what works and doesn't through evaluation. So we don't know it all now, but we've got ways of finding out through actually going out and finding out what works, creating the evidence around the initiatives that we have in health promoting health service.
Thanks, Andrew. We've got one question from Sarah before the final one from Ian.
I just want to go back to something we were talking about a bit earlier, which is about your performance and how we're measuring it. And you know, Andrew quite rightly said that public health programs are complex and partnership working is complex, so it's difficult to capture. Nevertheless, you talk in your self-assessment about some metrics. I've got two challenges really. I mean, the first is about language, because this is a complicated business, but I think there's a challenge about making it simpler in terms of how you present it and how people understand it. And if I'm honest, some of the language in the self-assessment and that we all use and use is overcomplicated, I would suggest. And I think for people out there who are customers, we've talked about a whole range of them, from health board non-execs to workplace people, the more jargon we use, the more complicated our language, the harder it is for people to access it. So I've got a bit of a challenge for you around that. And then about measurement and metrics. And the one I picked up, which are relating to healthy working lives, you talked about a 38% increase in the number of employers that access the services. I wondered if you were focusing really on the metrics that everybody would understand as performance metrics. What are some of the other examples that are really key? So recognising the complexity of it all. If somebody says, how are you measuring how well you're doing? What would your answer be to that?
Can I just start off by saying I think we absolutely accept that challenge or that point about the language in which we talk about all of this, and it's certainly something at my board we're quite persistent in that. And I think we'll just hold that. You're right, we need to be expressing ourselves more simply. Again, I don't want to just say it's very complicated. It's something that my board and our health governance committee have put a lot of effort into, is how do you measure your performance and particularly your effectiveness. We've just set up a stakeholder group to establish some key performance metrics for us, and these won't be just ours, they will be our stakeholders be saying you need to be held to account in these performance metrics. So to some extent that's one of the challenges I think for this coming year. I'm hoping by this time next year we'll be able to see something very explicit. I don't know, Kath, if you want to add to that briefly.
I think that covers most of it, Margaret. I think for me this is an improvement journey, it's a continuous improvement journey. We've come a long way. We have led the way to some extent around outcomes planning and reporting. I mean, we are speaking at Scotland's Public Sector Roundtable on Performance Management in a couple of weeks about the outcomes approach that we've taken. We're nowhere near the end of that, but actually we have got something to share about how we've attempted to even do what is extremely difficult about looking at shared outcomes, which a number of different organisations contribute to, and how do you work that back. there's always going to be, with the long-term outcomes, we're talking about an element of narrative, and there's no way getting around it other than describing it in quite broad ways about to what extent are you influencing policy. You have to give examples like we've given. But as Margaret says, you know, we recognise, and I think the Stakeholder Performance Forum, which is a number of other organisations have drawn in to help us with this, and we've had one meeting, the next meeting's tomorrow, and what they've said is, you know, let's work on this together because we can learn from this too. And it is about that nitty-gritty now of how do we add to that qualitative narrative and those good questions about how do we know we're making a difference, where is it relevant to have metrics, and that's exactly where we are, and we're discussing that with our group tomorrow, and we'll share that. But I think it's been a really good journey to be on, and I think it's something that's attracted a lot of interest from other organisations about how we do it and how we all learn from that.
So this time next year we might see some of that in your at a glance.
Absolutely.
Yes.
Indeed, and one of the things that we have to recognise, and I guess this is also the case for most public services organisations, there are some areas of work where it's much easier to describe that. So we have different programmes, for example, and I'm conscious two programmes that have come to Health Scotland quite recently, the Healthy Living Award and Community Food and Health Scotland, have elements of their programmes which are, I think, more suited. So we know the numbers of caterers, the number of catering outlets who have received the award. That's actually, although it might, going back to Ron's point earlier on, might still describe inputs, if we do know what the evidence tells us around the results change that lead to outcomes, then you actually can have a level of confidence that by investing in particular areas of work, you are more likely to achieve that outcome. But I hope you've taken some reassurance, Sarah, that this is in our sights. I don't think we'll come back with anything perfect next year, but an invitation to yourself and to people in the audience is, if you can help us with this, we're very interested.
Okay, thanks, Jerry. And that takes us to Ian for the concluding questions.
Just perhaps take it from a health board perspective. I think it would be just interesting. You've got financial challenges as all boards have. Perhaps just giving us an example of some of your efficiency savings would be of interest. But also looking forward, we continue the challenge to make those efficiency savings. How can we be more effective with the resources? I wondered if there was anything that Health Scotland could offer boards of support, advice in terms of how they can become more efficient and perhaps provide services more efficiently.
I'm going to ask Alan, it's quite appropriate for Alan to have the last word about that. The thing I would underline again is we do not get these savings to recycle. This is money that's coming out of about £1 million a year out of our budget. Certainly we've been very good at finding genuine efficiency savings. I mean, the example in the at a glance, our publishing team are really good. And I certainly think that's an area where we could help. A couple of years ago, we took the decision that all of our publications would be free, and I think that was something that was very welcome from local boards and helped contribute to their efficiencies. But it's definitely going to be a challenge, and I think we're going to have to think very hard about focusing, rather than just saying we can do everything that we're doing, but more efficiently, if we're having £1 million a year taken out of our budget. Alan, do you want to add to that?
Well, I think you've just said most of what I was about to. But I mean, I think that the important point here is that unlike other boards, our efficiency savings are generated but then returned to the Scottish Government, so they're not available for recycling within the business. So that is done by way of reducing our initial budget each year. And I think if funding, therefore, is not available to us, then it's available for use elsewhere in terms of an initial budget. So the challenge we have each financial year is to develop a business plan for the next year that enables us to deliver a fairer and healthier Scotland to the best of our ability, but also needs to be a plan that enables us to operate within declining financial resources. As to what else we can do to work with other boards to help them, I think it's important that in developing our business plan for future years, we're in discussion with all our partners about what we can do to work with them and help them. I think, as Margaret mentioned, we've changed a lot of our delivery mechanisms. I think we're producing a lot less now in the way of printed materials, training packs. We're doing a lot more online. And it's about, I think, trying to make resources available that people can tap into. Similarly, I think if there are good resources being developed locally, then hopefully we can pick them up and utilise them on a national basis. So I think it's about driving value from what we do internally, but also from working with all our partners in all these different arenas.
Ian, can I maybe pick up on a final couple of points about that? Because I think it would be fairly presumptuous of us to suggest at the scale that we are working how we might bring forward a lot of lessons for a board, say, the size of your own, because I think you're already doing the things that we would expect to be doing ourselves. We are a different board in the sense that we do not have the same exact demand-led pressures or front-door pressures that you have. What it means then is when we then come to agree how we will put a programme in place that matches the budget that's available to us, is that we are constantly now reprioritising what that might look like. And in relation to our workforce costs, which are more than 50% of our total budget, it means that we're having to think about where we prioritise as vacancies arise, our reinvestment of those resources and the reduced resources that we have. And in a couple of examples that have actually been alluded to earlier on, what our commitment around, say for example, the third sector might be, or our commitment around supporting the NHS. We've made important reinvestment decisions with those reduced resources this year in relation to key posts to drive our strategic approach around both third sector and primary care in particular. So that's the nature of the challenge. It does mean that as we plan out each year with what's been for the last 3 years £1 million less, that's a more and more difficult balancing act, and it's one which means that not everything that we've done in the past will be able to be maintained.
Margaret, we could spend another hour doing this, but we're going to conclude at that and offer the audience some time for some questions.
Right.
Yep, somebody there?
There's there. If you could just wait, there are people with microphones. Got a couple of questions there. And if before you ask your question, if you wouldn't mind saying who you are, that would be good.
Thank you, David Lascais, TMS Chief Executive. Very interested in a lot of the discussions that there was no mention of benchmarking externally, either on your equalities programmes or internally on your organisational development programmes. So I just wanted to understand the panel to comment on that.
I'm going to ask Kath if she'd like to say something about that.
Yep, and sorry, that was probably our omission to some extent. Benchmarking is something that we take seriously. It's quite hard to do in some of the specifics just because of the specific nature of us as an organisation, say with the rest of the NHS in Scotland and indeed in the rest of the UK, but there are specific things that we can do. The staff survey is a good example. That's a national staff survey, and there is opportunity for us to benchmark that against all other NHS organisations, and we have done that, and we're looking at the results. We're also part of the European, can I get this right?
EFQM.
The acronym is EFQM, thank you. I think what the long version of that is European Excellence Model, and with that very specifically there are opportunities to benchmark with other organisations. In fact, we've just completed an internal customer satisfaction survey and used the benchmarking models within that, and it's told us, and that's been able to benchmark out with just the NHS but other organisations offering those kinds of services. I think when it gets into inequality, I'll see whether other members of the panel want to add, but that is probably our challenge, partly because there, as far as we know, no organisation directly doing what we're doing. But Jerry, I don't know if you have any thoughts to add to that.
No, I've little to add to that other than to say, Mary, that again, this is an issue that our board has continued to ask us to be thoughtful about how we develop clearer opportunities for us to benchmark our own performance against others. So a very active discussion, and again an invitation that if you have advice to us, we'd certainly more than welcome that advice.
Another question there.
Yes, I'm Jonathan Shear from Wave Trust, and it seems to me that Health Scotland has played and is continuing to play an important leadership and support role. There is an issue about the extent to which the emphasis is on closing the inequalities, closing the gaps, versus preventing those gaps from from opening in the first place. And preventing them from happening in the first place, all the evidence suggests very much means giving priority to the various early years and to the life course. All of that is mentioned in your documents, but it's a question of balance and priorities. And so I'm curious, looking ahead, as to the extent to which you're going to help Scotland make real all the aspirations that we all share about prevention is a good thing, early years is a good thing, reducing domestic violence and child maltreatment are all good things. But we don't seem to have a great handle on actually accomplishing them. And so I'm interested in looking ahead what that prevention agenda looks like and how we're going to keep inequalities from starting in the first place rather than always playing catch up to try to close the ones that have already.
Just to start off, I mean, I think you've given a really good description of what our challenge is. I think it made it clear at the start. I mean, it's extremely important that we take action in all different fields. It's not a question of choosing. We'll focus on fundamental causes or environmental causes or individual. The challenge is that we have to see action in all three of these areas. And the challenge for us is how we do that in amongst all the change and complexity and reducing budgets. I don't think we see it as an either-or thing. Jerry, do you want to add to that?
I'll say something, maybe invite Andrew to as well, and I absolutely share your own view, Margaret, about the importance of us considering all of those different levels of intervention. I think you've heard us say something about our contribution towards where we see a particular focus within public services through community planning partnerships. So you have all of local public services coming together and looking at the potential for prevention. And I think most CPPs certainly have quite plans in place around early years, and not just the early years collaborative, but absolutely get that, and indeed some of the additional investment that there's going to be in early years provision for a greater number of children. One of the other things is that post-referendum there is clearly now a very active conversation around the powers that Scotland already has, the powers that Scotland will have next year, and under Lord Smith's guidance, the potential for additional powers that might come to Scotland. I suspect, particularly given that I know that there's a very large third sector representation on the floor today, I suspect you will already be looking at some of the evidence that we've brought forward and that we will continue to bring forward in order to shape for your particular organisation's mission, to shape the kind of recommendations that you might want to make in that continuing national conversation around how powers are used. As one of my colleagues said at the start of the referendum campaign, when asked the question about whether an organisation like ours would be recommending either way in the referendum vote, he said it would be entirely inappropriate for a public body to make that kind of recommendation to Scotland's population. It's for our electorate to decide that. But just because you have the powers in order to make different decisions doesn't mean you necessarily use them. So there needs to be a very active, ongoing conversation around about that. Andrew, anything you want to add?
Just briefly, to quote Marmot, this is about a generational change. It is not something that we can pick up 1 year and drop 3 years later. And one of the lessons of, I think, policy over decades is that we've got to sustain our efforts. So I think you're right to spotlight this area. And Jerry has mentioned already the early years collaborative. But if you're going to look at a best start in life, you've got to look at child poverty. You're going to have to look at poorly paid young parents in work. How topical is that? You're going to have a look at wider nurturing and community valuing of children, the health of women, health of young people generally, children about to be parents who are in trouble, and our interaction with education and justice in these areas. We're in there, we're doing things there. Our investment will be sustained in these areas, but we do need to sustain them. And I think that's the key word. It's a generational issue. It's not a small, short programme or a campaign.
Any other questions in the front table?
Scottish Council for Voluntary Organisations. So I've got I suppose a question and an offer. It's not that long ago that the poor people were blamed for their poor health. And so the extra travel is going to be, I think, will very much welcome. And that's great, but NHS is a very big ship to turn around. And so getting the system when health inequalities was less important than it is now in terms of learning, then you perhaps miss some of the discussions we're having here today, we're having in the ongoing work. So I guess my question is there scope to influence education at undergraduate level and in terms of continuous professional development to make sure people who joined the NHS some years back and didn't get that as part of their learning can now switch on to a different way of doing things, so you blame people for their poor health, to understand the circumstances make a difference. The offer is really related to the area health boards in particular, but also to yourselves who would offer help, and that is that Ian's organisation, but more than very many other organisations around today, can help to connect the local health boards with third sector organisations that give voice to people who experience health inequality. So please give us a resource to help build hearts and minds to change practice and to create a fairer and healthier Scotland.
I think that's potentially a question for everybody on this stage and not just for Health Scotland. I think education is obviously important. Again, as part of our role in advocacy and strategic engagement, it is about making sure the folk who can change things are aware of that. And we've got colleagues in NHS education, health education, NES, Education Scotland, and obviously we have and are consistently talking to them, and we do joint training with them as well, and we are consistently bringing that focus on health inequalities. So that's part of our continuing role in advocacy and strategic engagement. You know, that's the jargon headline, but that's going to be part of the work that we undertake. Does anyone else want to? And I'm extending that invitation across the table as well. I think it's interesting. We were talking about this earlier. We have been doing more work with the third sector. The third sector have been really great and have wanted to talk to us, partly because they see us as a way into the health service, which I think is reflecting back for local health boards that clearly folk don't find it that easy because the NHS is big and it's complicated. So maybe folk, we all, as colleagues in the health service, need to think about how easy it is and straightforward it is for local groups and indeed community groups to actually interact in the way we would all like them to interact with the health service. I don't know if either...
I think there's a general issue about engagement, Margaret. I'm talking about the third sector, and I see Claire Stevens is here from Voluntary Health Scotland. I missed her earlier. But there is a big issue about engagement. I think things are a lot better now than it was. But that lack of engagement, and Paul alluded to undergraduate training, I can speak for the University of West of Scotland in this context. I mean, universities would be as disengaged from other groups as Health Scotland might be, or as the third sector might be. So there's a premium on building partnerships and making connections. One of the things that we've strongly advocated in Quarry Alliance is the business of trying to make infrastructure a bit tighter, making connections nationally and locally. And Callum Irvin's here from Voluntary Action Scotland, is a third sector interface organisation. There are 32 third sector organisations paralleling the 32 health and social care partnerships, working and not only in health and social care but in other areas as well. But so there are points of connection that can be made, and the challenge for me is that even in a locality, even the lead in person-centred care, for the sake of an argument, in Ayrshire and Arran, might not be connected to the local third sector. It might be, but might not be. And therefore things might sail by as busy lives catch up. So that process of making connections, building connections, making partnerships work is one that Health Scotland have re-embarked on very strongly over the last few years, but it needs to happen in every territorial health board as well.
I've just got time, I think, for one more question. Well, very brief, and we'll try and answer them briefly because we're cutting into our lunch. Okay.
Good morning. My name is Fraser Taylor from Suspension Scotland. Dean, I just wanted to pick up on that point there. In each of the last 2 years, you and I have attended the budget setting process of the Scottish Government. in relation to integration of health and social care, in each of those last 2 years, there's been an appeal from the third sector to either compel or bypass the statutory infrastructure because it isn't working. I think what you described this morning is the need for a cultural change, not a technical change, not a change in budgets, not a change in allocations. And I look at the work plan for 2014-15, and indeed in pages 5 and 6, or 6 and 7, should put my glasses on, the key partners and key deliverables. Again, the third sector is fifth and the sixth of the key partners. But community planning partnerships and health and social care partnerships are identified as separate from the third sector. The third sector are absolutely part of those partnerships as well, and indeed should be. I think there's a cultural change that's required here to see the third sector as something different, not as something separate that needs to be engaged with in a tokenistic process. So my question, my challenge is, as you put it previously, are you genuinely willing to engage with the third sector in a different way?
We have to be brief here, and I would say we've got this afternoon round the table to talk about that. And I'm sorry that the third sector's number see that as fifth on the list. I mean, I absolutely take the point that you're making, and I think what we need to work through is what that means for us. I mean, I think we've done well in terms of how we've been approaching the third sector and thinking about how we engage with you. And the challenge for us is how we start to make, build on that and make it more real. And again, be able to answer the question, well, so what? What difference has it made to the people that we're all interested in serving? So I think I'd maybe like to just keep that one for later this afternoon. I hope you don't think we're not answering it. I've got 2 more questions. They're going to have to be the last, if we can be brief.
My name is Dumucha Mishaka with the Bogotá. At the beginning, it was mentioned about looking at the implications of welfare reform in either increasing health inequalities and increasing the gap between those who live with the experience of health inequalities and those who don't. To me, that also falls under the fundamental causes of the health inequalities. But what I don't see is the response in terms of the mitigation. For example, today there was an announcement yesterday with the minister saying that they are now going to introduce smart cards, which means that people with the experience of health inequalities will not actually be able to access health services if they don't have money upfront to go and access health care. What would the NHS do in terms of influencing such political decisions that are more counterproductive rather than helping people to access the services intended?
I think it's a really powerful question. Who would want to answer that? Andrew.
You sat forward first, Andrew.
I mean, I entirely understand your point, and I'm very sympathetic towards it. But there are political policies that we try and influence, and the sooner we get to politicians, the better. But sometimes you cannot get to them before they've made a decision, and that may be one of them. We have commented to politicians. I appeared before a select committee in London in January on behalf of directors of public health on the impact of the spare room substate bedroom tax, and we are engaged with politicians, but that's an illustration of a time when we appeared when the damage had already been done, and it was mitigating the damage of the policy as it was being implemented. So we are trying to move upstream, influence policy, as well as deal with the consequences of it.
Right, and we've got one last question here at the front. Someone in the front row. Yeah.
Very briefly, Bill Payne, built environment for Scotland. We're doing quite a lot of work with very early on the impact of the built environment on health. My question is, do you feel that when health issues come up in things like planning or building model or whatever it is, that you're getting the right sort of responses, either at the strategic level from government or perhaps from local authorities, understanding the needs for health to be built into new development?
Well, can I just say before I'm going to not yet is the answer. I met this year with the Royal Institute of Architects in Scotland, and it was really interesting that their interests are absolutely aligned with ours. They're interested in good design, and they're thinking about how that impact, knowing that that impacts on health and well-being. We're interested in good design because we know that that impacts on health and well-being as well. And so we're starting, I think, to see that realisation and understanding. Whether we're where we need to be across Scotland, I think that's the answer to that, probably no. Andrew, do you want to add to that?
We are doing work with planning in the government. We're doing work with Architecture and Design Scotland. We actually have run a couple of meetings with architects in Glasgow who are interested in social housing and macro planning in localities. So we are getting into this. I think the short answer is it hasn't been good, but it's getting a lot better.
Okay, thank you for that. And I thank you for your patience and for cutting into your lunch hour. On behalf of Health Scotland, I'd like to thank the panel for taking the time to be here today and to quiz us, I think, quite directly about what we've been doing and exploring some of the challenges with us. This afternoon, we're going to have the chance for everyone in this room to talk about the next bit. What are the main areas of work that we should be working on? How should we be approaching that? We're now going to break for lunch. Lunch is through the door and to the left. Given that we have eaten, we don't want to undo everyone's digestion. Can I ask if we come back about 10 to 5 to 1 to start the afternoon session? So thank you again. Thank you.
Oh, sorry.